This is Lung Cancer 2, and it gives me great pleasure to introduce our chairperson, Dr. Sumit Agarwal, who's a nuclear medicine specialist from Udaipur. So I invite Sir to introduce our first speaker and to start the session. Over to you, sir.
Hello. Good afternoon, everybody. Now this session is for lung cancer part 2. I would like to invite Dr. Gaurang Modi for the immune checkpoint inhibitor real world experience for India in advanced tumor from India. Over to Dr. Gaurang Modi.
Respected teachers, seniors and colleagues. First of all, I would like to thank you, Dr. Manoj Mahajan, for this wonderful conference and especially bringing the Indian spices to this conference. So the topic that is given to me is immune checkpoint inhibitors in advanced lung cancer, Indian perspective. So these are the outline of my topic. So if you see the Globocon 2020 data, we see the 2.2 million cases that we see as a lung cancer incidence per year. And if you see the mortality, it is approximately 1.8 million per year. But if you see the Indian data, that are 72,000 new cases per year. So I would take this data as a pinch of salt, because we all know that we have the poor registry system and we need to strengthen our registry system. And if you see the lung cancer, according to the histology, there are mainly, especially two types of the histology are there: non-small cell lung cancer and small cell lung cancer. In non-small cell lung cancer, there are adeno and squamous. But in my OPD, we usually see nowadays a different kind of complex histology like adenosquamous, full differentiated Dr. Somani had sir described. Also some type of tubular mucinous histology are there. And in my OPD, usually the cases are stage 3 and stage 4 non-small cell lung cancer or advanced stage of small cell lung carcinoma. And if you see the 5-year survival data in advanced stage 4 cancer, usually it is less than 10%. So how Indian etiology is different compared to Western? Usually the smoking is the most common cause of any lung cancer. As true for the Indian patients, also there are oral tobacco consumption. But something that is very interesting for Indian subcontinent are Indian indoor air pollution. Also there are use of the domestic or biomass fuel exposure. Also there is lack of micronutrients in our diet. Also there are some unique occupational exposure are there, and also there is endogenous or mycobacterial pathogens are there. So that could be a compounding factor in our etiology. So what is the mechanism of immunotherapy in lung cancer patient? Nowadays the tumor microenvironment are the buzz around the cancer pathophysiology. Whenever the cancer antigen present in our body, that is sensed by the tumor antigen presenting cell, that is dendritic cell, and that dendritic cells activate the T cells, and that activated T cell increase and trafficking another activated T cells, and then subsequently kill the tumor cell that is present in the tumor microenvironment. So that is normal, and that's why we are immune normally to cancer. But in cancer, whenever happens, this axis is disrupted either by poor immunogenicity of the tumor cells. Also there are reduced dendritic cell maturation. Also there is suboptimal T cell activation. Also there are impaired T cell trafficking even after cancer cells present in the body, and decreased killing of the tumor cell by the T cells. So mainly two players are there, that is PD-L1 and PD-1 receptor. So PD-L1 is a ligand, and whenever there is binding of PD-L1 with PD1 receptor on activating T cell, that is down regulating of the activated T cells, and there is immune escape phenomenon for cancer cells are there. So if you want to attack these cells, you need to check either PD-L1 antagonist or PD-1 receptor antagonist. So there, here is the come for the role of the immunotherapy are there. So PD-L1 expression determined by the ISC, that is already discussed. But as a medical oncologist, whenever I prescribe PD-L1 by ISC, pathologists ask me which method or which molecule do you want to use. As Dr. Jay sir said, there is almost similar concordance pattern between Ventana and DACO, but somehow there is some miscommunication are always there. So usually PD-L1 less than 1, it is negative. PD-L1 low, that is 1 to 49% of the tumor cell or 1 to 9% of the immune cell. And if PD-L1 high, that is more than 50% of the tumor cells or more than 10% of the immune cells. So how many patients that we see are PD-L1 positive, TMB high or MSI high? So there is some connection is there, but again the connection is not concordant, as MSI H patient are 3% positive, TMB high, that is tumor mutation burden patient are high in 7.7% of the patient, and PD-L1 is positive approximately 1/4 of the cancer patient, and these are the data of Western, and 1/3 of the MSI high patient are TMB low. Also 1/4 of the MSI high cases are PD-L1 positive. So according to this discordant, in 2020 NCCN panel removed the TMB as an emergent immunomarker. Based on that, you can use immune checkpoint inhibitor. And this already discussed in previous discussion why PD-L1 is not perfectly predictive, as different detection methods are already there in the market. Second point, there is some glycosylated form of the PD-L1 and usually it is not recognized, so you have to deglycosylate first. Also tumor heterogeneity are always there, and most important point is this: previous treatment with the radiotherapy could be a compounding factor. As PD-L1 positive patients, you see there is a increased PFS and OS advantage, but some of the patients have received previous radiation therapy and that could be a compounding factor as well. So what are the treatment options available for driver mutation negative metastatic non-small cell lung carcinoma? So in previous day we are using single agent chemotherapy, then gradually we are using the double agent, then targeted therapy after the event of the Gefitinib, then a newer generation of the targeted therapy, and now the immunotherapy is on the card. So I usually classify metastatic non-small cell carcinoma according to the driver mutation status, whether it is present or absent. So there is arsenal available for driver mutation positive metastatic non-small cell carcinoma, but there are very few options available if there is driver mutation negative metastatic non-small cell carcinoma. Like we have option available only chemotherapy, immunotherapy, anti-VEGF inhibitor, dual chemotherapy or dual immunotherapy in first line as well as the second line setting. So what are the options available right now in India? All options are available, like Atizo we have, Pembro, Nivo, Durva, we all the options available, but what are the data? So if you want to use immunotherapy in a first line setting of metastatic non-small cell lung carcinoma, and what are the data that suggest we can use as a single agent immunotherapy, that is Atizo we can use according to the IMpower 110 trial, and these are the patients are usually PD-L1 positive that responded well, and if you see the data, there is clear cut advantage of 7-month overall survival data. And if you want to use Pembro, there is a Keynote 042 trial is there, and that suggests that 8-month absolute overall survival advantage, and in Keynote 024 trial there are 16-month absolute OS advantage. And there is a new chap in the market, that is Sapilimumab, and trial is going on. And also there is immunotherapy related specific side effects are there. Usually they are very well tolerable by the patient and easily treated by the steroid. And if you want to use combination, that is chemotherapy plus immunotherapy, you can use chemo plus immuno irrespective of the PDL1 status. If you want to use Atizo plus chemo, the trial data available, that is IM power 130, and there is a almost 6-month overall survival advantage. There is a non-regimen ABCP regimen, Atizo plus Bevacizumab plus Paclicarbo, according to the IM power 150, and there is a 5-month absolute overall survival is there. And if you want to use the Pembro plus chemo in Keynote 198, there is a data and absolute 13-month OS advantage are there. So if you want to use the second line immunotherapy in metastatic non-small cell carcinoma, there is a data. So if you want to use the Atizo, there is a data of OAK trial, and approximately 4-month OS advantage is there. And for Nivolumab in the squamous cell carcinoma, irrespective of the PDL1 status, there is an advantage of 3 months. And for Nivolumab in non-squamous etiology, irrespective of the PDL1 status, the advantage of approximately 4 months. And for Pembro, the guideline says that you have to do a PDL1 status, and if it is more than 1%, you can use it. So what about the Indian data then? And the whole topic is that what about the Indian data? So I have searched Google and find out some 6 to 7 trial. First, there are only retrospective data are there. First data, that is by Dr. Vanita Nurunna from TMH Mumbai, and the total number of patients were 155, and they used Pembro and Nivo as a second and third line of the chemotherapy, and it was done between 2015 to 2018. And usually the lung cancer patients are 76, and most of the cases patients are adenocarcinoma more than compared to squamous cell. And they used 97% cases Nivolumab and only 2.6% Pembro, mainly because of the cost issue. And they have used Nivolumab as a 3 mg per kg every 2 weekly or 240 mg flat dose every 2 weekly. For Pembro, they were used 200 mg flat dose every 3 weekly. And if you see the Indian tolerance of immune checkpoint inhibitors as a side effect, pneumonitis was there for 3 patients, that is 1.9% as a grade 4 side effect, and couple of grade 3 side effects are there like hepatitis, pneumonitis, colitis, encephalitis, hypophysitis, mucositis, and fatigues. And if you see the response, almost 42% patient had some response. And for conclusion, median PFS of immunotherapy among non-melanoma patients, solid cancer was 2.57 months, and if you see the overall survival, it was 5.37 months. Main thing is that the patient they were used are mainly second and third line and the poor performance status. Second data, that is from Dr. George Abraham. Total 1000 patients are there, and they included 13 centers in India. And again, it was an observational study between 2014 2020, and most of the patients received short course of IO, and mainly in the second and third line of the setting only. And if you see the response rate, approximately objective response rate was 25.1%, stable disease in 20%, and if you see the clinical benefit ratio, that is CBR, it was approximately 45%. Third data is from Santosh Kumar. The total number of patients are 88, and they have included 4 centers in India, and they have used Pembro, Nivo, and Atizo. Again, they have used Nivo more. they have included 3.4% of patient of EGFR positive, and total patient who are that PDL1 testing was done was 39, and out of them 11 patients were positive for PDL1, and they were used Ventana SP263 and Daco 22C3, and they were used mainly nivolumab, and most of the patients are second line and beyond. So these are the data, and if you see the objective response rate is approximately 25.6%, and clinical benefit rate is 46% approximately. Fourth is from Dr. A. Rauthan et al. And a total number of patients they have included in the trial were 70%, and they have specially noticed the side effect of the immunochemotherapy.
So sorry to interrupt you, sir. Can we ask you to conclude?
Sure. Okay. So another data, Dr. Vinit Gupta are there, and then Dr. Naresh Somani, and then Dr. Wasim Abbas. But just want to conclude that the Indian data are mainly retrospective, single arm, and they are only observational study or in form of the case series, and the clinical benefit rate was approximately 30 to 45%, and most of the patients have taken IO in a second, third or beyond line, and side effects were mainly thyroid dysfunction and pneumonitis, and grade 3 and grade 4 side effects are very sparse, and most of the Indian patients match the clinical benefit comparable to the Western population with the same tolerance. So we need prospective data and double arm study to support our existing figure. Thank you. Any question?
Quick comment. So thanks for including my study also, though it's the number of patients were less only.
Yes, sir.
But two things I would like to highlight, and Professor Malhotra is sitting here, Vijay Patil is sitting here, they will agree with me that initially when these drugs were being introduced, it was being said that one has to be very good internist to use these drugs. But over a period of time, we have learned that it is not exactly like that. All sort of these ITs which are being written in the books or being prescribed in the literature probably are not being seen. And in my particular study in Indian patient, what we have seen that the hyperglycemia is the more common, hypothyroidism is less common, and other toxicity fortunately I could not see in my patient, especially the hepatitis and the colitis. Thank you.
Welcome.
We'd just like to remind our participants and also just let them know that there is running tea and coffee at the back, so you can have it at your leisure. With that, I'll hand the mic back to Sumit sir.
Thank you, Dr. Gaurang, for such a nice presentation. Now I will like to invite Dr. Abhishek for next presentation.
Yeah, so thank you, Manoj, for inviting me. And basically, I hadn't put my slide up front because I thought the theme, conference theme was respecting and publishing or respecting the Indian data. So I was asked to talk about TKI with chemo compared to just a TKI or Gefitinib. So I had put up this slide as first slide. Respecting the people who had done it, one of them is here, Vijay is here. So this was work from Tata, which was published in ASCO. It was the original presentation from TMH, was put in ASCO 2019 about Gefitinib with chemo compared to just Gefitinib alone. So I thought it was very apt for these guys to be put first beyond anybody's name. So this is the original presentation. I have taken few slides from it, and let us see what the background to this entire concept is first. So you can clearly see this one slide will tell you everything. This is practically everything we know about first line, second line, third line TKIs, and how do you treat patients with EGFR mutation with TKI. So these are the first line trials. If I have to summarize, don't go through the details. If I have to summarize patients with on first line TKI like EGFR would generally have a PFS from anywhere from 6 to 9 months, maximum maybe 10 months. Then came the second line, and you had the second generation TKIs, Gefitinib and Decomitinib, and you had a survival which improved from maybe median PFS improved to 12 to 14 months. Lastly, you had the third generation TKI in the form of Osimertinib or Tagrisso. So now you landed up with 17, 18 months. So what the original trial, probably that is what I can make out, was done before the Osimertinib data had actually was so rigorously followed or had come out. The trial was planned much before that. So the things have dramatically changed after the third generation TKI have come. But still, if you look at these are all the this is all the data we have about a TKI being combined with either chemo or a targeted therapy or any other treatment. You would like, we are using generally in our clinical practice, a TKI is a single agent. So this is TKI with TKI with a chemo and TKI with a targeted therapy like a bevacizumab or a Cyramza. So what the TMH guys did was they proved that combining a chemotherapy with a TKI would result in a better PFS, although OS was still lacking when the data was presented in 2019. So the background to this trial was this phase 2 trial. This is a Japanese study. This is a phase 2 study which showed that combining a Gefitinib with a Pemetrexed Carboplatin would lead to an improvement in the PFS from a median PFS of 6 to 7 months to a median PFS of 10 to 12 months. This was the original trial which was done by the Japanese guy. This is a phase 3 study, the NEJ-009, where it was randomized in a double-blind manner. The randomization was done where TKI was compared with TKI with chemo. And what they concluded is, as you can see, the response rates are better. The PFS in the combination arm was better. So you can see the PFS in the combination arm improved from 11 months to 20 months. Great. And what they had smartly done is they had subsequent lines of treatments were also defined. So they were able to pull off OS data as well. So this is the last slide which was available to us that proved that OS was better. But let me tell you, the ESMO which recently concluded in Paris, the final data has come out which has said that there is no OS advantage. So it's just a PFS advantage. One of the negative points to the TMS trial is that there was no OS data which was given out. So Dr. Vijay Patil is here, maybe he can put in the word. The Japanese data is finally concluded that there is no OS advantage, there is just a PFS advantage. So let us come to the thing which we are here to present, the Indian data. So this was the original trial which was done at TMH, and the authors were from Dr. Kumar Prabhas to Vinita Norona. And this was stage 3B4 patients, advanced disease, EGFR positive, and EGFR mutation was done basically in the local lab at Tata, and no differentiation was done, any EGFR mutation. It was taken, and obviously performance status and ECOG and everything was considered. It were randomized to either Pemetrexed Carboplatin with Gefitinib, 4 cycles followed by a maintenance of Pemetrexed Gefitinib, and in the second arm it was Gefitinib alone. There was no chemo there. So they basically wanted to look at PFS, OS, toxicity, response rate, and quality of life, which they haven't yet concluded or put up as far as I know. Quality of life has not come out, OS has not come out. The PFS and OS is all there, and as well as toxicity is what they have concluded. This was way back in 2019. It has been 3 years, but I don't think we have any more data from Tata after that. So Vijay is there to back that up. 712 patients were selected, out of which 350 were taken into the trial, 170 in each arm. No rocket science in that. Why I highlighted the 700 part is that one of the criticism again, which we'll come to then in the last slide, is that they took a lot of patients, they were screened, and possibly the best patients were taken. That is one of the criticism of the trial. It was not a blinded and a double-blinded study. It was an open, and a lot of patients were selected and put on the trial. A lot of patients were deselected as well for various reasons, which basically generally does not happen in a double-blind randomized trial. So first let us see the bad part of it. Obviously, combining a chemo with a Gefitinib would result in toxicity of the chemotherapy. We all know what happened is all grade 3 toxicities you can see from 50%, which was probably very high for a Gefitinib arm. It still landed up with a 75% all grade 3 toxicities in the chemo plus Gefitinib arm. And as would have been expected, a lot of neutropenia, a lot of GI side effects, a lot of gut toxicity was there, lot of uncommon side effects as well. Amongst them were nephrotoxicity, which would have been expected in the Pemetrexed arm, hypokalemia. So basically the side effect profile was far worse than the Gefitinib arm, as would have been expected. The toxicities were doubled. The good part is the response rate, which was expected in the phase 2 and phase 3 data as well, had improved from nearly 60% to 75%. So the responses were better, which would have been the case when you combine 2 drugs, 3 drugs. Ultimately, what conclusion they came up is, you can see, probably if you can, it's a very blurred slide, but the PFS improved from 8 to 15 months, it was doubled, and the OS was 17 months in the Gefitinib arm and not reported in the Gefitinib plus Pemetrexed Carboplatin arm, and it has not been still reported. So we conclude that it is better because they had put up a final conclusion there. So across all subsets, the medicine in male, female, ECOG performance status, the combinations was working better. As would have been accepted, there is a lot of criticism in this trial. The negatives, that it was a single institution study. As I told you, a lot of selection and deselection was done. It was not randomized. It was not a blinded study. It was an open label design. No centralized review as well as pathological and radiological reviews. But the positive parts were still there. The positive part was that, yes, you could combine Gefitinib with chemo, and you could give better responses. You can get a better PFS. OS, obviously, we did not have that. These were the conclusions that they gave, that Gefitinib with chemo, the PFS improved from 8 to 16 months. The 18-year OS is what they had put up finally, improved from almost 48% to 78%. So meaningful improvement. And obviously, as I told you, the toxicities were doubled from 25 to 51%. So one of the last conclusion was that it is one of the first line options for patients with EGFR-mutated lung cancer. So this is what the data stands from India. But I thought, let us add something to it, why this entire concept was brought forward. So you saw the first one, Vinita Nura, you saw the NEG-009. A couple of other trials, one of them which is recently being quoted everywhere around, everywhere and anywhere, is the relay trial. So this was the first trial which came up, was combining an erlotinib with an bevacizumab or a VEGF inhibitor. And the subsequent trial was the relay trial, which compared another VEGF inhibitor in the form of Cyramza with a erlotinib in a randomized fashion, a lot of patients. And what they concluded is that definitely it led to an improvement in the PFS. So you can see what they smartly did is where we did not, is that they separated the two subsets, 19 and 21, L858, in a different way. So 19 we obviously know is very good, and you will bound to have good responses even in the Gefitinib arm, even if we don't add chemo. But 21, L858 is a poor subset. So what happened is, in this trial, you can see L858, exon 21 mutation, the PFS improved even better. The single agent Gefitinib was obviously considered to be a poor drug for an L858. Osimertinib is better at that. But compared to Gefitinib, your erlotinib, your Cyramza erlotinib landed up with a PFS of 19 months compared to just 11 months. So another proof of concept that if you are using a first generation TKI, you might add a chemo, you might add a anti-VEGF inhibitor. No harm in that. It definitely improves the PFS. Whether the overall survival increases is still debatable. So as I told you, consistent PFS benefit in both groups, 19 and 21, but 19 is supposed to be good. So you might still argue 21, it showed improvement, so it's something to be used for in the first line. So that is where Cyramza with Gefitinib Cyramza with erlotinib has come in most of your first line recommendations in NCCN and ESMO and all the guidelines. And there are several new studies going on combining osimertinib with bevacizumab. One of them is a phase 3 study which will possibly see the data in the near future. So what finally I would like to conclude is, so you have the first line TKIs, as I told you, you have 6 to 10 months PFS. You go to the second line, you might use your chemo, you might use osimertinib. If it's a T79 positive patient, you might use an immunotherapy. You land up maybe at a PFS of anywhere from 20-25 months, maybe even 30 months. You have an option of using a first line osimertinib, which was not there when this trial was done. So if you are using first-line osimertinib, your PFS is already 18 months, as has been claimed. And if you use a second line and a third line after that, you use a chemo, you use an IO, you use all your VEGFs, you might end up at a PFS of 35 months and maybe an OS of 50 months. But what has happened is a third dimension to it is you use a first line TKI in the form of erlotinib or a Gefitinib with a chemo or with a VEGF inhibitor like Cyramza. Again, you have a PFS of 18-19 months just like your first line osimertinib. Then you go to your second and third. If the patient is T79M positive, what happens here is you have an option of using a second line osimertinib. So critics will argue both ways, that if you use osimertinib first, after that you have nothing to do. Or you use all sorts of things after that, you might land up with a PFS of 25-30 months and an OS of 50 months. And if you use a first line TKI chemo or a TKI with an Avastin, then you go to osimertinib if it is T79M positive, and then you go to your chemo and immuno, you might still land up with a PFS of about 30 months and an OS of 50 months. So both those arms are probably well balanced. Obviously, the crucial part is, as I have just put, would you do a chemo with TKI in every patient, and what advantage would it be? Because it has a lot of toxicity. So a chemo with TKI with Cyramza makes still sense because of very minimal side effects. What about using a TKI with a chemo? So I thought, since we are honoring our Indian data, there should be some positives out of it. So there is still some positive out of it. One of the main positives is not everybody in India can afford a Avastin or a Cyramza. So what about people, most of our patients, 99% of the patients who cannot afford this Cyramza or a bevacizumab and osimertinib to go with it. So what do? You do a chemo with a Gefitinib or an erlotinib, especially if you are young patients. So that is where I made a smart differentiation to it. If you have a young patient, you have a fit patient who can tolerate both, circumventing the side effects, so possibly makes sense. Does not have all the money for us, the Cyramza or an osimertinib, it definitely makes sense. Suppose the patient has only EGFR-19. So I think EGFR exon 19 mutation would still do very well on a Gefitinib. I would be still reluctant using a chemo with a TKI. But suppose he has a EGFR exon 21 mutation L858, which is far worse than a 19 or even a 20 for that matter, which the Tata guys had taken. So those do very miserably. In that case, young fit patient, you might use a chemotherapy with a TKI in that patient. And I think still it stands as a very good regime, especially for a country like ours, where Cyramza and Avastin and osimertinib is out of the reach of majority, 98% of the patients. So it does make sense in using this regime, and I am also using it personally. But then there are certain things which need to be looked at before jumping into it. And possibly the data from Tata could also have been presented in that way. But I think Dr. Vijay Patil is here. We did not have any other data after that 19. And there is no other major data across the world also with this combination. There are small phase 2 data everywhere here and there, which all say that there is a PFS advantage. The last hit to the trial was the ESMO 2022, where the original Japanese trial also failed as far as OS goes. So there is where I stand. Thank you. If you have any questions, you can ask, and Dr. Vijay Patil is here. I was also very keen on asking whether we are going to have any more data from that trial.
Dr. Abhishek has a lot of questions for Dr. Vijay.
So, my senior is Dr. Amit Joshi. He's one of your colleagues in this trial. I called him several times whether we have any more feedback or data from this trial. He said no.
So, Dr. Amit concentrates mainly on uro now, so he doesn't concentrate on thoracic. So first of all, this was a randomized study. Whenever you do a randomized study, you will have inclusion and exclusion criterias, and patients who are not fitting the inclusion and exclusion criterias will be removed, won't be screened further. So there is no like selection, deselection. There is a process called screening, and if the patient is not fitting into inclusion and exclusion criteria, you are supposed to put them on the consort so that everyone can have an idea about, like if you would have seen the consort, patient who declined to consent, patient who had a poor performance status, or patients who had a deranged LFTs and RFTs were not taken in the trial, and that's the reason that consort.
So I am fine with that. This is one of the criticism of your trial.
No, it is not a criticism, doctor.
So fine,
You need to understand that if you have any randomized study, whether it's flora.
So
whether
why
it's
so many
Adora.
patients? Actually, I think overall you have selected 1500 patients.
No, it was
700 was the last thing you put
so,
up.
so let me speak. It was 700 patients and 365 patients, roughly 300 something. 50% patients out of which are screened is a good number. Dr. Hemant is here. When you do it for pharma, only 20 or 30% of the patients of the screening actually land into it. So 50 is actually a good number. Putting it across, if you see the osimertinib flora study and the other studies which were done for immunotherapy, they hardly took patient of PS1 and even those who have brain mets. This is the only study which has a good number of PS2 patients. It has patients with brain mets. So it is more near to the real world data. Second, when we always talk about osimertinib, saying that osimertinib did well, we always forget that the Asian subset of osimertinib, the hazard ratio was bang on 1. So we are not very sure that osimertinib works in Asian patients or not. And this was actually a surprise because when the study was being done, that time osimertinib was not available in Asia. It was available in the North America. So the feeling among the investigators was that probably in North America you may not get an OS benefit because the patients would receive osimertinib in the second line. But in Asians, you definitely would get an osimertinib because it was as such not available. But in spite of that, there was a benefit seen in the North America, not in. So before jumping on to osimertinib, we need to have some more data, whether it's as good as in Asians as it is. Second thing is OS data was reported and you actually showed that slide. And NR,
that was 18-month data.
Let me complete. And NR doesn't stand for not reported. NR stands for not reach. If you look at the median,
so, but then I would say it is not reported yet.
Nah, NR doesn't start for not reported.
No,
If
so
the median survival,
that.
if you go back to the curves, you need to understand the Kaplan-Meier's curve. If the curve doesn't cross the 50% line, it will be written as not reach. And when you don't have data which is not reach, you tend to give like the nearest endpoint, like it was 18 months in this, you need to put at 18 months how many proportions were in one arm and how many proportions in the other arm. If you see that the proportion was more than 50%, and that data needs to go. Second, about quality of life data of this study has been presented by Dr. Nandini Menon already, and the manuscript is already been submitted to this. And the conclusion was addition of chemotherapy didn't lead to a decrement in quality of life. Third thing is adverse events. We are very flimsy, and I find it very surprising and good that this lecture is after the PDL1 lecture. We were ready to combine Pemetrexed, Carboplatin and Pembrolizumab. We were ready to combine Pemetrexed, Carboplatin, Bevacizumab with Atezolizumab. But somehow we are very flimsy when we have to combine Pemetrexed, Carboplatin and Gefitinib. We are the same medical oncologists. For a PDL1, we are ready to combine Pembro, 4 drugs, but we are very afraid to combine Gefitinib with Pemetrexed, Carboplatin. I find it very difficult to digest that how the same medical oncologist is very comfortable when it comes to PDL1 patients but not to this patient. Let's talk to long-term data. See, the analysis are not based upon 2 years are done or 3 years are done. A certain number of events need to have for a meaningful analysis to be given. The last time the data when it was reported, the reason why 18 months was because the median follow-up was still 18 months. This is 3 years. We are actually waiting for the median follow-ups to reach to around 5 years, because there is no point in giving the notion that 2 years this was there. So probably this ASCO, already the data, you would be seeing the 5 years update of this results. And we also have actually got started because to our surprise, the NEJ came down to be, overall survival came down to be similar. But there is a caution here. If you looked at the initial NEJ report which came in JCO versus now it came to in the PCO, you would see that the median outcomes of PFS and OS which were reported, those medians have actually dropped down in the final the recent report which came, and even the clinical update which came in JCO, which actually means that probably they had a lot of censoring which was done, and the over-censored data gave those good results. In fact, we had a lot of questions which came when Japanese data came, because our data was nowhere to be matched to the Japanese data. Their medians were in 40, 50 months. Ours were in 20 and 30 months in and around. So we need to wait for the long-term data to come. I agree with that.
So that is what I am asking you.
So that you probably would be seeing this ASCO if ASCO accepts it as a poster or a in this part.
Yeah, so it's not a criticism that I put up. It's a criticism in general, but then what I was interested in knowing is where are we right now? That's it.
It's not a question of criticism, but we need to put the trial in the correct perspective. We can't be saying selection and deselection of patients.
That is why last slide, if you saw my last slide, I had put it in the clear perspective, because in the Indian setting.
My point is, you cannot say it was not reported when the graphs clearly showed that it was.
Last you reported was 80 months.
I think let's stop this and go on, please. Thank you very much. Thank you.
We'll move on to our next session. This session is sponsored by Novartis, and I invite our speaker, Dr. Renu Mishra, medical oncologist from Udaipur, and she'll be talking on the topic personalized therapy to further improve outcomes in patients with BRAF-mutated and SCLC. Over to you, ma'am.
Good evening, everyone. So today I would talk about personalized therapy to further improve the outcomes with BRAF-mutated, non-small cell, metastatic and SCLC cases. So my objectives would be to cover the understanding the role of BRAF in metastatic and SCLC, gaining awareness of BRAF testing methods and diagnosis of BRAF positive and SCLC. To review the clinical data of dabrafenib and trametinib in advanced non-small cell lung cancer. So first the introduction about the BRAF pathway, that is the MAPK pathway. So MAPK pathway is the mitogen activated protein kinase pathway. It regulates the cell signaling from transmembrane growth factors leading to cell proliferation. So any oncogenic mutation in the MAP pathway, including the BRAF kinase mutation, they have been reported in number of human cancers, and lung cancer is one of them. BRAF mutation result in constitutive BRAF activation and thus the uncontrolled signaling by the MAPK pathway, which we can see in this picture, the KRAS, BRAF, MEK, MAPK. This pathway is mutated in a lot of cancers. Melanoma, 50 to 60% cases we see BRAF mutation, and the data from melanoma has been extrapolated and put into use in colorectal and lung cancer as well. So BRAF mutation in NSCLC, BRAF mutation occur in around 1 to 4% of non-small cell adenocarcinomas, and BRAF mutation typically do not overlap with other mutations, that is the ALKRAS, VEGP2. In contrast to other oncogenic driver mutations, the key patient characteristics are not very well characterized with BRAF, like it does not correlate with the age, sex, stage or smoking status. However, there has been small contradictory studies saying they are more common in females or smokers, but there is no conclusion about it so far. Although V600E is the most common BRAF mutation, occurring in 50 to 70% of the BRAF positive cases, other mutations are also there. And the diversity has important implication because the strategy, the targeted treatment we have is for BRAF V600 mutation. There are various other mutations in the BRAF which we can see here. So what has been seen is that patient with BRAF V600E mutation, they have a shorter median disease-free survival and overall survival than patients without these mutations. That is, these tumors are more aggressive and patients have a worse outcome, especially if they are treated with conventional platinum-based chemotherapy. Outcome in patients with BRAF V600E mutations versus those with wild type, if we compare, if we look at this table here, the clinical outcome we can see with a BRAF positive patient, the overall response rate with the first line platinum therapy is just 29%, and the median PFS is 4.1 months, median OS is 10.8 months. So treatment still remains suboptimal for patients with BRAF positive, BRAF V600E positive NSCLC. So approximately 1/3 of patients remain untreated, that is 33% have been found to just been given best supportive care. 52% patients have been given platinum-based doublet chemotherapy. But what has been seen is that as with all the other driver mutation positive lung cancers, this also shows a better survival if we treat it with a targeted therapy. So patient with non-squamous NSCLC without mutated AL cross currently receive chemotherapy or immunotherapy, and followed by, as we have discussed, followed by the maintenance, and if the PS is not if PS is 3 or 4, then best supportive care. But if we choose broad molecular profiling, that is, we include BRAF testing at the onset, then we can identify these patients at the onset and treat them. So current consensus guide us to include BRAF along with EGFR and AL cross, as it is stated in NCCN now, that we should include BRAF testing, and so a broader panel through NGS testing should be done. So upfront BRAF testing is needed so as we can quickly identify and treat these patients. And there is no clear clinical risk factors like age, sex or smoking history that we can choose such patients. So now looking at some of the data for dabrafenib and trametinib combination. So dabrafenib and trametinib, they target different kinases in the MAPK pathway. Dabrafenib it is a selective inhibitor of RAF kinase, while trametinib is a highly selective inhibitor of MEK1 and 2 kinase activity. And this drug is the combination of dabrafenib and trametinib is DCGI approved for advanced non-small cell lung cancer with a BRAF V600E mutation. So what is the rationale of this combination? Why do we use a doublet? So as it was seen in the studies in melanoma, that using a single drug can lead to resistance and the activity of single drug is less. So double drug delays resistance, and they both act synergistically in BRAF positive cases. So the approval for this drug has come from a phase 2 study, and this study included patients with stage 4 BRAF V600E positive patients with the PS of 0 to 2. They had no treatment with BRAF inhibitors, and patients with more than 1 centimeter brain mets were excluded in this study. This study had 3 cohorts. Cohort A and B had pre-treated patient. Cohort A received monotherapy with dabrafenib, while cohort B, they received dabrafenib and trametinib combination, while cohort C, this had treatment naive patients and they received BRAF directed therapy first line. So the primary endpoint was overall response rate, and the secondary endpoints were PFS, DOR, OS, safety, and the population pharmacokinetics. So what was seen in this was the cohort A, where the median age was 66, male-female ratio was they were equally balanced. Whites were the majority of the patient, and 2/3 of the patient were current or former smokers, and nearly all the patients had adenocarcinoma histology, and almost half the patients were in the second line or beyond. In the cohort B, this group received the doublet and they were also treated previously. These all patients had adenocarcinoma, and 3/4 were current or former smokers, and 1/3 of patients had received more than 2 previous lines of chemotherapy. Now coming to cohort C, these were treatment naive patients. They were being given BRAF directed therapy first line, and all these patients had adenocarcinoma histology. And as we discussed the primary endpoint, this is again showing the trial features. So now this is the assessment for the cohort A. I'll show the comparative slide directly. So this is the final efficacy summary, where dabrafenib and trametinib was more effective than dabrafenib alone in previously treated patients. So cohort A patient, where monotherapy was given, the overall response rate was 33%, while when the combination was given, this response rate improved to 63%, and in the treatment naive patients, previously untreated patient, there the overall response rate was 64%. The disease control rate was 75% in the cohort C, and the PFS was maximum with treatment naive patient, that was 10.9 months. So overall we can see these patients fared far better when they were treatment naive and started directly on BRAF directed therapy. So coming to the adverse events, so it was observed pyrexia as the most common side effect, even in the monotherapy arm and in the combination arm. So, but however, most of the adverse events were in the grade 1 and grade 2. There were very few patients who had to live, around 14% for who had to discontinue the treatment because of adverse events. So pyrexia was the most common adverse event, that was 46%. However, only 2% had grade 3 pyrexia. So so how do we manage pyrexia if it comes across in our clinical practice? So we have to interrupt the treatment if temperature is more than 38.5, and we can interrupt dabrafenib, and trametinib can be continued. However, some studies say that we should discontinue both the drugs, and we can initiate antipyretics like ibuprofen or paracetamol, and if the patient still doesn't respond, then we can start oral steroids. So the pyrexia management is first we have to look for any infection or hypersensitivity, and all the lab work for that should be done. And the first thing we have to manage is hydration. Patient should be hydrated very well if in the event of any pyrexia. The antipyretics we should start, interrupt dabrafenib, and once pyrexia resolves in the first event, we can restart dabrafenib at the same dose. And if fever is associated with dehydration or renal insufficiency or hypotension, like any complication, then we have to reduce the dose of dabrafenib. In the second event, we treat as same for first event, but we consider steroids. And in a subsequent event, if it happens beyond second, then we should interrupt dabrafenib and restart. Whenever we restart, it should be at a reduced one level reduced dose. So what is the starting dose? The preferred starting dose is 75 mg, 2 tablets, that is 150 mg of dabrafenib and 2 mg OD of trametinib. The first dose reduction is 100 mg BD, and for trametinib it is 1.5. Second is 75 and third is 50. And if patient is not able to tolerate 50, it is preferable to discontinue the drug. And this drug, they should be taken without food or 2 hours after a meal. So to sum it up, the safety profile was manageable and pretty much similar to what the melanoma study showed. The most common adverse events were pyrexia and GI related toxicity and skin reactions. And pyrexia was the most frequently observed adverse event in all cohorts, and it is manageable by the pyrexia treatment protocol we just discussed. Thank you.
Thank you, Dr. Renu, for such a nice presentation. Now we have the panel discussion. Recent advances in management of small cell lung carcinoma. I would like to invite Dr. Bhavesh Parekh as a moderator, sir, and all the panelists, Dr. Sri Salurkar, Dr. Abhishek Kakroo, Dr. Sunil Kumar, Dr. Manish Advani, Dr. Saurabh Gupta, and Dr. Nilesh Patira, sir.
Thank you, Chairperson. Thank you, my esteemed panelists. Again, thank you very much, Dr. Manoj Mahajan. My topic is update in the management of small cell carcinoma. Before this, my panel discussion, I think Dr. Abhishek Kakroo as well as Dr. Gaurang Modi already speak on the non-small cell, EGFR-mutated and unmutated. My panelists is, I think, 2 pulmonologists, 2 physicians, as well as 2 medical oncologists. Is it okay? All the 6 panelists is there? Okay. So I think a pulmonologist and physician, yeah, one pulmonologist and two physicians. Okay. So I will start with presentation. This is a case presentation. Before starting that,
I didn't understand that.
is that slide this not shown here? Yeah. So my question to the physician that how frequent you come across a patient with some obesity and come in your OPD with some complaints like cough and breathlessness that ultimately turn out not a tuberculosis but a lung carcinoma?
Very rightly said, sir, because in this developing countries or Southeast Asian region, tuberculosis are first to be considered.
Absolutely.
Definitely. But I want to highlight that under the heading of tuberculosis, definitely we as a physician, sometimes we miss this lung carcinoma or lung malignancies.
Correct.
So,
correct.
And vice versa too. Sometimes the CT scan shows sometimes that is a metastasis or some malignancies also, and when the biopsy comes, it will turn out to be tuberculosis.
Correct.
That is also the vice
Absolutely.
versa.
Absolutely.
But definitely, when we talk about the tuberculosis, under the headline of tuberculosis, we should highly suspect, because what happened, being a physician or very busy OPD sometime, we think, oh, that patient with breathlessness, weight loss, cough with expectoration, nothing else other than tuberculosis.
Correct. Correct.
So we should, being a physician, we should not stop our side to have a more enthusiastic investigations in terms of CT scan, if the or CT guided biopsy, if you think some mass or some opacities are there, and if possible, then we can go for the bronchoscopy and bronchoscopy guided biopsy to confirm that part. So definitely in our OPD setup, at least in some patient, those who having a breathlessness, weight loss and cough with expectoration long duration, which is sometimes treated or partially treated, sometimes they like periphery, sometimes they will be on ATT, they have started ATT, like that is called a ATT trial. Because without diagnosis of tuberculosis, they start the ATT.
Absolutely.
Okay, if nothing is there, then ATT will work.
Correct.
This is the common dictate.
Correct.
So we should not stop ourselves. So somewhere approximately 15 to 20% of patients where we are suspecting tuberculosis, and it will be turned out to be a malignant part.
Perfect. Perfect. So that's the background again, rightly said by a pulmonologist. My topic is on the small cell carcinoma, and as such, small cell carcinoma is account for 15% of the all lung cancers. It's highly aggressive, poorly differentiated, high-grade neuroendocrine malignancy, poor 5-year survival. I think my earlier topic was on the non-small cell, and I am talking about the small cell. The 70 to 75% of patients present with the metastatic disease, and the 5-year survival is dismal, less than 3%. The paraneoplastic syndrome commonly associated with small cell lung carcinoma. Again, these are the tumors, chemosensitive and radiosensitive. However, this is very important. In spite of early response rate in order to 60 to 65% to standard cisplatinum carboplatin plus etoposide based chemotherapy, outcome remains poor. Median OS is around 10 months with limited progress made over the last 2 decades until recently. So this my background slides as far as the pulmonologist or physician is concerned. Now this typical patient, 60-year-old female, presented in January 2020, left side chest pain, cough and weight loss. Again, you had mentioned about the long duration, or most of the times the patient is treated by somewhere else. So I think other two physicians also. Have you come across, suppose in your busy OPD, this type of patient, are you ordering CT scan, PET scan or X-ray chest?
Sir, frankly speaking, as a physician or internist, we tend to be reluctant towards sending a patient for further imaging beyond chest X-ray and also for a fiber optic bronchoscopy, which should ideally be done in a patient of tuberculosis also, so that we do not miss small cell cancers.
Correct.
Yes, sir.
Okay. Any other panelists?
Initial investigation we do is chest X-ray based on the symptoms, and when we see some suspicious opacity, we go for CT thorax.
Sir, sometimes practically as a super specialist, sometimes we had a patients with PET scan and CT scan but no chest X-ray.
Yes, sir. That is also.
So sometimes that's what I want to find out from you point. So this patient or patient having a CT scan thorax, again having a 4 centimeter lesion left lower lobe with spiculated margin, very important, and abetting diaphragmatic pleura with bilateral hilar lymph node as well as paratracheal and subcarinal lymph node. There was right supraocular lymph node. Please, this is also very important. 4 centimeter lesion, left lower lobe and right supraocular lymph node. As a physician or as a pulmonologist, one is intensivist, how you go ahead?
So next step should be take the biopsy from the most easily available site, that is right supraclavicular lymph node.
Correct.
So we should do FNAC or biopsy from the lymph node.
So again, as a super specialty, Abhishek, your comment is like the word has been used FNAC or true cut biopsy. Are you happy or you are only stick to the true cut biopsy from right supraclavicular lymph node?
Sir, we'll stick to the biopsy.
Okay.
No FNAC.
Any other comment? Rather than supraclavicular lymph node, sometimes, especially the word FNAC, sometimes it is inconclusive or sometimes the reported is malignant cells are seen. Not more than that. So are you interested as an intensivist for the bronchoscopy, or the other question is CT guided biopsy from the primary lesion, that is left lower lobe lesion?
Sir, actually it depends on the location of the tumor mass. If it
Correct.
is centrally located, we'll definitely go for
So
a
again
fiber
it was
optic.
a peripherally located?
Yes. So peripherally located CT guided biopsy is a better option. We
Okay.
get a good tumor tissue,
Okay.
so that we can analyze it further in
So
detail.
sometimes the mediastinal lymph node sampling or the EBUS or the bronchoscopy guided biopsy is also important. Are you happy if it is a peripherally situated for a CT guided biopsy or a true cut biopsy, as again Dr. Abhishek Kakroo mentioned about the right supraclavicular lymph node?
Sir, the approach we'll have to see where we can get to the tissue.
Okay.
The minimal invasive approach.
Okay.
And we can get the maximum out of the biopsy lesion. I think my pulmonologist friend would add something about the bronchoscopy part.
So the once the biopsies came, either you are still referring to a medical oncologist, or if there is something written by the pathologist and your also colleague of super specialist feels that you have to go for repeat biopsy. How come across such type of things that that super specialists again refer back to you for a repeat biopsy?
I think in that case we would like to discuss with our super specialist colleague.
Okay. Or rather than pathologist colleague?
All of them be clinical, patho and radiological.
It will be good if, because sometimes what happened, we send biopsy to the pathologist,
Correct.
but sometimes they don't know the history of the patient. That
Correct.
is very important. So clinical pathological correlation definitely play important role in this part.
So I think again when we refer to a pathologist or when we send that sample, I think again the history is very important.
That is very
or
important.
written, that most of the times we are not written.
Either the pathologist should be your friend, so that you can have a telephonic conversation that I am sending this patient with
Yes.
this short history.
Yes.
So that will be good, and for the pathologist to look for that part actually. That is
Correct.
very. Sometimes we get a retrospective callback from the pathology department. Sir, you have sent this biopsy or FNAC. What you are suspecting?
Correct.
Sometime.
Correct, absolutely. So most of the time the pathologist is also asking or us that what is the radiological finding or what you have some clinical suspicion. Especially that patient had already taken a tuberculosis treatment or ATT or not previously, or patient is a very fresh case or a new case, and directly as a pulmonologist or physician you are suspecting some malignancy, like the report of the CT scan thorax. like some lymph node, some metastasis, opposite side lymph node, or a typical 3 centimeter, 4 centimeter lesion with a spiculated margin. So most again the clinical presentation of small cell carcinoma, local symptom cough, dyspnea, chest pain, hemoptysis and hoarseness. The distant symptoms is weight loss, weakness, anorexia and paraneoplastic syndrome, again very important. The paraneoplastic syndrome is either ectopic hormone associated or it is immune mediated. Again, this patient has biopsy from the mediastinal lymph node, is a bronchoscopy guided or EBUS, and biopsy is initially the histopatho report is malignant round cell tumor. They have not specifically mentioned, and finally it was IHC has been done from that same specimen because the tissue is enough to do a IHC, and that is positive for synaptophysin, chromogranin, CD56 and pancytokeratin. The final conclusion of that pathology report from the mediastinal lymph node is small cell carcinoma. Abhishek, are you happy in this stage, or still you are interested to do some more pathological workup, or as a medical oncologist super specialty, this is the CT scan, biopsy and IHC, 3 point with clinical judgment. You are going to start your treatment.
Sir, biopsy wise I am fine, but
Okay.
only thing is I would still disagree with the extensive stage part. I would like
Yeah,
to,
that's what that at present we should not write.
So
Absolutely.
the only thing
It's just a small cell
yeah,
carcinoma.
yeah. So what more I would like to do is some more radiological workup to rule out extensive stage.
So that more radiological
So
workup
it,
means?
it could be a PET scan, or if it's the PET scan is not available, I would like to do a whole body scan with the brain MRI in this
Okay.
case.
Okay, so I think in this case CT scan thorax has been done. So answer is either PET CT scan. If it is not available, then whole body scan with MRI brain. Arulkar sir, are you happy? Okay, so I think whatever the staging workup, so I am still interested that what should be the workup investigation for small cell lung carcinoma. The standard investigation workup include contrast CT scan. Sometimes we had done a plain CT scan. So again the word contrast CT scan of chest, abdomen, pelvis, FDG, PET CT if available. Again, MRI brain, unilateral bone marrow biopsy in case of abnormal blood count. Sometimes in a small cell carcinoma like we are considering paraneoplastic syndrome, or sometimes associated with abnormal blood count, either thrombocytopenia or there is a high WBC count, we are suspecting something, extensive bone marrow presentation or bone metastasis. In CT scan thorax it was not again mentioned about the bone window, but sometimes in CT scan also they have mentioned about the spine metastasis or the vertebral metastasis. And molecular profiling is reserved for the patient who have never smoked and have extensive stage small cell. So Abhishek, molecular profiling is at this stage either generally we are doing or we are avoiding or we are keeping reserved.
Sir, if I am sure about small cell, I don't think it matters if I do any profiling at this stage or not.
As far as the PDL1 is concerned or other any NGS?
Not needed.
Not needed. Not needed. So I think we are very clear that CT scan thorax, most probably PET CT, if not then full body scan with MRI brain, at least for small cell carcinoma, because and that again with that confirmed biopsy report or with that IHC report, because in non-small cell lung carcinoma compared to this small cell carcinoma, the brain metastasis or asymptomatic brain metastasis, again this patient does not have any complaint related to the brain metastasis. Patient is not symptomatic for the brain metastasis as well as for the bone metastasis. So again diagnosis, again I will stick to the biopsy, and this is staging. Again that was a, sorry, it was a blackened out, but generally T1, T2, N0, M0, that is stage 1, limited stage, that is only 5% incidence, and any T, any M or M1, that is stage 4, extensive stage, is generally 65%. Again, there was no, I think, colleague of any surgical colleague, but I think as a physician, have you referred any such type of case to a direct a CT surgeon or a onco surgeon, small cell carcinoma or any lung carcinoma with that presentation, right supraclavicular lymph node, hilar lymph node, as well as 4 centimeter left lower lobe lesion to a surgeon, operable, T1, T2, N0, M0, stage 1, rare, less than 5%.
It is hard to, as a tertiary center, they are hardly comes to us in the stage of limited disease.
Correct.
Whenever time they will be treating by the periphery for the some infection. Sometimes the facility is also not available. They are based on the X-ray they are treating, or it could be pneumonia, it could be anything else. So whenever the patient comes, there will be almost the end part will be included. So it will be extensive disease. If you refer that, then again they will refer to the medical oncologist. Okay, this is extensive disease, so no need for go for surgery.
Absolutely. So Mani sir, your comment, small cell carcinoma, refer to a surgeon. T1, T2, N0, M0, small cell.
So there are two comments that the conventional teaching had been keep surgeons away from small cell lung cancer. That is the first comment with due respect. And second is that yes, in the very small lesion, still surgery is being indicated. And suppose you have diagnosed based on FNAC, someone has the non-small cell or poorly differentiated, and you have done the surgery and it has turned out to be small cell cancer, then you have to treat that patient according to small cell guidelines. That means limited stage. So these are the 2-3 points I would like to make.
Absolutely. So even at all, if the surgeon has done a surgery, again you have to treat. Yes sir, Malhotra sir.
So I think just to expand on what Naresh has said, one of the reasons why most of these patients are inappropriate for surgery is that they are all heavy smokers.
Yes.
And
Yes.
they have advanced COPD.
Correct.
And even if they are operable,
Yeah.
they can't be operated because of the bad pulmonary functions.
So again, the
So that's
pulmonary
why-
function test is also very important.
Yes,
as far as
and some patients, small number, maybe less than maybe 5%, you
Correct.
might need local treatment
Correct.
in the form of radiotherapy.
Absolutely, absolutely. So this history is also very important. The smoker or not smoker. Again, this a female 60 years, but that part is also very important as far as the history is concerned. That whether patient is smoker or non-smoker. Because again, if you are operable, but as Malhotra's point, sir point is that we have to ask or we have to call for the pulmonary function test to look. Might be the other lung or other part of the lung is not that much that having a. So this is the standard like evaluation of the systemic therapy. As we all know that might be this patient is not a surgical candidate and is a case for Arulkar or Abhishek Kakroo sir. And this is the 1970 we had a CMV, as Malhotra sir also witnessed that part. We are not witnessed, but CAV, might be CAV, me and Dr. Arulkar sir might be we are given. And latest is 1990 or EP, that's what me and Dr. Kakroo or other colleague is also giving. The most important today is checkpoint inhibitors. So answer, Kakroo, chemo or immuno?
If
I think now only point is that now it is extensive stage.
It's extensive stage.
Absolutely.
So if money is not a consideration, then both. Otherwise, it would be purely chemo.
Okay. So if money is not the part, then both. How you will combine both?
So you could use cisplatin or carboplatin etoposide with any of the two agents, durvalumab or atezolizumab. Probably you have cis and carbo, both options for durvalumab, and atezolizumab you will have only one.
Correct.
But chemo 4 cycles with the immuno, followed by a maintenance of the immuno till progression.
Perfect. So the answer of this particular patient is that chemo plus immunotherapy. There are at present two options, either atezo plus durva, and 4 cycles. The agent either you can use cisplatinum or carboplatin. That's a platin with etoposides. Arulkar sir, are you agree with this? Add PCI after these 4 cycles, or depend on the response. If it is a very good response, then at least add PCI, that is prophylactic cranial irradiation. So this patient again started with cisplatinum etoposides. The post 3 cycles, we have to give, Abhishek Kakroo sir told that it's a 4 cycles with immunotherapy. In this case, we had given only chemotherapy, so we had started with 3 cycles. And again in my first slides, that generally this type of tumor is chemosensitive or radiosensitive. So initially it was a very good response, but overall prognosis is not that good. So this patient having a complete regression of the left lower lobe mass with complete disappearance of the lymph node, except only one pretracheal lymph node, that was 11 millimeter. So patient continue the 6 cycles of chemotherapy. In May 22, presented in January 22. So within 5 months, the patient has completed 6 cycles of carbo and eto. And as again Arulkar sir says that if there is a complete metabolic response, then at least you should go for PCI. Now this patient already received PCI also after in the June or June 20, and then so this is the issue that considering PCI, Aruka sir, are you also interested in local chest wall radiation if it was a complete response with the 6 carbohyto or only PCI?
No, only PCI. I won't offer.
Only PCI. Immuno or observation, as Kakroo sir, you told that Atizo or Durva, if we had given 4 cycles with chemo, then maintain with the IO. So in this case, suppose immuno was not given. So now only 6 carbohyto given. Whether now it's a role of any immunotherapy?
No, we will observe.
Perfect.
And I would be really tempted to give her chest wall RT as well.
Absolutely, absolutely. That's what I want to discuss this point is also. So again, a role of immune checkpoint inhibitor, again in limited stage, we are talking about the extensive stage. I think time's up, so I will sum up whatever there are total 2 trials or different trials, like initially it was ipilimumab also was given, and that ipilimumab trial was again failed to show the benefit. Now that first line Atizo, again in extensive stage, not in limited stage. So the role of Atizo as well as role of Durva, both has been given extensive, and this Caspian trials, and again IM power and Caspian conclusion is that it is important to stress in both trials that only patient with a good clinical condition, this is also very important, the performance status, and in stage 4, that is extensive stage, Atizo or Durva in combination with platinum plus Ito should be offered to all eligible chemotherapy naive patient with stage 4 small cell and PS of 0 to 1. That's, I think my panelists also discussed or agreed. Now I am again talk about the another, that's pembrolizumab, and this is again maintenance, as this patient does not receive initial IO, so that again there was no conclusion that we should continue or maintain with the immuno, but Nivo and Ipu both had tried for the maintenance immunotherapy also. Now coming back to this case again, in March 21, so almost the disease-free interval is 10 month, from June 20 to March 21. Again patient is no complaint, but routine checkup, every 3 months we are doing CT scan, and this almost 1 year is over, that's why we had started again PET CT scan, and in that it was a recurrent lesion in the left hilar with same left lower lobe, so it's a recurrent in the same size with left supraclavicular lymph node. Now this is a left supraclavicular lymph node, not right. Rebiopsy again from the left supraclavicular, and it was small cell carcinoma. Again role of second line chemo or immune checkpoint inhibitor, Dr. Kakroo.
Second line chemo, and if immuno is not been given in the first line, maybe we could use that also. No role for NGS or a PDL1 still.
Okay.
No role for a radiation.
So I
well.
think role of PDL1 we are not, because in small cell I think is respective of the PDL1, the immune checkpoint inhibitors or the immunotherapy is given. That's why there was no role of PDL1 or NGS.
Another one word which we could add is, because we have physician friends here, that it's for a very minimal benefit of 2 to 3 months that you are giving some immunotherapy. So very judiciously to be used in patients who are really good performance status, and there is absolutely no issue of money, because the benefit is very limited, and so there is so
this patient already received that chemotherapy, but now is after 10 months of disease free interval, as such also extensive stage, their overall prognosis or overall survival is only 10 months, and this patient from January 20, now we are in March 21. So again a patient has taken now second line chemo, as again Dr. Kakroo tells, and that is cisplatin plus irinotecan rather than etoposide, but now patient is interested to take immunotherapy. Atezolizumab has been given in a second line setting. Again after 3 cycles of chemo plus immuno, more than partial response, and now radiation to the lung as well as radiation to lung has been given. So after 3 cycles with again second line the post chest wall radiation, so there is a role of thoracic radiation therapy again in a small cell there are 2 or 3 trials, but again finally this patient is post radiation to the local chest wall, as patient is in a remission or in a partial response with 3 chemo plus immunotherapy. Now patient is absolutely fine, again asymptomatic. Now in PET CT scan that 21, that is a mild metabolic activity, that is after 3 months or 6 months, 3 months of chemo and chest wall radiation therapy, the SUV is only 3.5, and patient is now with continue ATIZO, that is immunotherapy maintenance. Again, this is the treatment algorithm. November 21 now. Again, there is a right supraclavicular lymph node, very big mass, 7 to 9 centimeter, breathing difficulty, cough and hemoptysis. Now we had explained about the IO plus IO, means 2 immune checkpoint inhibitor. Patient is already on 1 immune checkpoint inhibitors, and now there is a progression. Kakroo, any answer? Arulka sir?
Best supportive care.
Best supportive care.
So I would use what you said, even I have used. I'm not so young. CAV.
CAV, yes. 1970s protocol or 1980s protocol. CAV, that is a third line chemotherapy after using cisplatinum ito or cisplatinum irinotecan. So again, oral etoposide, that is also one of the option, and CAV is also one of the option rather than going for. So these are the various options of the second line chemotherapy. Again, nivolumab or other immunotherapy also been given, and this patient again now after 3 months or 6 months of oral etoposide, more symptomatic, tracheostomy has been done. Again, patient has been restarted with immunotherapy, but now not responding. Patient finally expired in April 22. So January 20 to April 22, that's almost 24, 26 months in an extensive stage, small cell carcinoma. That's the suffer or journey of these patients. This is just a theoretical part, but most important part is now we had so many clinical trials and so many new drugs also, and these are the futures where Pembro, Nivo, EP and another so many other molecules is come across in a small cell carcinoma. We had now so many other options, driver mutations and immune checkpoint inhibitors, but there is a long way to go. Thank you. Thank you very much.
Excuse me, sir. Excuse me, sir.
Yes.
My question is that very aggressive small cell lung carcinoma.
Correct.
At the time we almost tried everything recently. Absolutely. As well as everything.
Correct.
So, being a medical oncologist, is there any screening tool of the person who is having a 55 or 80 years of age, or having either continuous smoking or stop smoking few years back, or having a pack year more than 3?
There is a screening tool that's called low dose CT scan.
Yeah,
especially in a high risk patient, as you rightly told, for a heavy smokers or a 50 or 60 years of age. But sir, again, to be frankly, in India, we had, sir, as you also rightly told, the tuberculosis, and again with this low dose CT scan, especially, sir, what my observation is, in a COVID era, where we had done so many CT scans, where we found a stage early lung cancer or esophageal cancer. Yeah. So I think, but at present, I am not advocating any screening tools, but definitely yes, if my patient or my OPD patient, especially for the pulmonologist, for a physician, when you come across any in your OPD of 50, 60 years male patient, heavy smokers, cough and breathlessness, such type of patients should be at least undergo CT scan thorax to detect as early as possible. But again, our epidemiology of a small cell or non-small cell, for a small cell, 65% are in extensive stage rather than localized stage. The localized stage is practically less than 10%. That's a curable, or that's a operable, or that's we can achieve more than 5 year survival rate.
Yeah, thank you, sir.
Malhotra sir, last comment sir.
So I think I'm particularly impressed with the young man's comment, Abhishek's comment, that the benefit, Abhishek, don't mind if I call you young man, because by relatively.
No, we have told the young and experienced.
So my take-home message to at least our younger colleagues is that immunotherapy in small cell lung cancer has a very tiny benefit, just 1 or 2 or at the most 3 months. So you have to use it very judiciously. It is not a modality which significantly adds to only chemotherapy, and it has to be used very carefully. Absolutely. Even for the CGHS patient or the TPA patient, ultimately it is coming out of your and my taxpayers' money. Absolutely. So it has to be used very carefully, very judicially in the right patient. We should not get carried away by the enthusiasm for immunotherapy, and we should not get carried away by what the industry tells us and sells to us.
Absolutely, absolutely.
To add what he was saying, the problem with low-dose CT scan is you should answer it. How many of your patients you are expecting would repeat the scan regularly, intervally?
Yeah.
The problem is you'll do it once, you'll do it twice, third, fourth time, it'll never come up. So it defeats the entire purpose of it, especially in a country like India.
Yeah, for oral cancer, screening, oral examination we cannot do in our country.
Correct.
So just let alone leave aside low-dose CT scan for the whole population. Regarding screening, we
Correct.
cannot screen our population.
Absolutely.
But for a very high-risk patient who comes to a physician
Correct.
or who comes to a pulmonologist, then you must, look at the X-ray carefully and maybe get a CT scan done.
Absolutely. Thank you, audience, for giving me. And as sorry, I am little bit late, but thank you, organizer, that can accommodate me in such a wonderful session. Thank you very much.